Okay.
So yeah, so we can proceed with it. Now I'd like to invite Dr. ARUP BHAUMIK from Disha Eye Hospital. He's a prolific surgeon and he can operate 50 cases in a day and all premium IOLs. And let's hear from him about post-operative assessment and realignment.
This is a almost simple post-operative assessment and realignment procedure. I just want to share. This is a post-operative surgical surprise or residual astigmatism. What could be the option? It may be the wrong IOL, your biometry or your calculation is wrong, or there may be misalignment. Either misalignment, your axis marking is wrong, toric axis marking wrong, or there is a IOL rotation. These could be the possibilities. So if you see the workflow, it's a biometry and keratometry transfer, the toric calculation, IOL calculation, reference marking, axis marking, and the alignment, IOL element. These you have to, in very busy practitioner or in a hospital, you have to depend on many person in this transfer. So it is very very much possible that there may be something wrong in this stage, and you have to take in an IOL rotation, which can be happen, but this part actually is a your wrong IOL, and this part is a malalignment. This talk I will concentrate in the misalignment part mainly. So threshold, what would the threshold of the monofocal toric? If you see some kind of residual astigmatism, what is the threshold? This threshold actually varies from patient to patient and surgeon to surgeon. So, but for a multifocal toric, threshold is very less. It is only 0.5%, because if you see the multifocal IOL, there is astigmatism, the chronoid stem, and the only one factor for the diffusion and another factor for the diffusion, and it is actually create loss of. And there is a paper presented, study presented in 2010. Only 0.5 astigmatism reduce the restore plus 3 lens from 6/6 to 6/12 part. So this is possible in case of so we have to understand the validation and effectivity of toric IOL calculation also. So we should not jump into the every cases to be perfect and rotate every cases. So it means this is the most popular Barrett IOL calculation, and it has only 85% accuracy. So 0.2 is a benchmark, 0.3 is a benchmark, and that is a almost, if you that is a almost 20% of the toricity intent to correct. It has a only 85% accuracy in the Barrett toric calculator. But yes, definitely who are using Barrett TK Universal 2 or Barrett TK toric calculator, in the which is available only in the IOL Master 700, the toric accuracy is 92%. So there is a study, the misalignment, axis alignment of toric IOL and error at postoperative rotation. And every cases of 72 toric techniques IOL was in a study, and digital photograph taken in the after 1 hour, after 1 day, after 1 month, and after 1 month, and seen the most of the surgical alignment is wrong in the 28%, and there is a rotation of IOL in 61%. All cases which is rotated in postoperative period. So the most important time for the rotation of the IOL is basically in the first 1 hour. So if you have as Dr. Shati has described, if you have a digital marking system, it can avoid the reference error in the reference marking and the axis marking part. But if you have a Callisto system and the biometry system, that directly transfer your data in the OT by lab. So what are the rotational stability is depends on the perfect incision, relatively perfect size rexis, slightly smaller rexis, avoid anterior capsular polishing, complete OVD regular, avoid inflate AC at the end of the notch the IOL and the capsular back, ensure position once speculum is off. And rotation instability is a complete unfolding. If you complete your case before the unfolding case, this is the most common. An incomplete VD removal and large capsular bag, large rexis, wound leak, overinflate of AC. This is a very important factor that can rotate the IOL within the after post-operative period. And I will design definitely all the IOL. I can IQ Toric is a the different study. The IQ Toric shows the most rotational stability. So how do if you have a refractive surface? So you have to identify the axis. You see the Toric calculation. If you mark the actual axis, and if you collaborate in the residual astigmatism and the identity IOL axis from the mark of the actual axis where the lens should be. So if you can calculate and you can assume that it is okay, then you can decide whether you go for rotation or not. You can straight away go to mark again and go to OT and rotate the IOL. And how do you calculate this? You can definitely go. I suggest everyone to go. This is a astigmatism.com. This is a wonderful website. This is a free website, and you can do the calculation with this. But how do you identify the axis? Note the horizontal axis in slit lamp, mark that, take a slit lamp photo in retro resolution, and adopt Photoshop, which is cost 7 version. It is cost only 1400 rupees. You can, where is your caliper, you can identify the axis and rotation of the IOL, actual IOL. You can identify IOL axis in the mobile app. Already Dr. Shafi described. You have a slit lamp photo with the IOL mobile holding IOL photograph system in your. This is a cost almost 1,000 or 2,000. You can take a photograph and you can identify IOL axis. So now the refractive surprise identify your IOL axis actual marker, but not collaborating with the residual astigmatism. So what to do? You should check the biometry, repeat the keratometry, and repeat calculation, and fix what is the wrong in the. If it is a wrong IOL, even astigmatism fix.com gives you the what should be the best in that wrong and calculation. This is how it is looks like. You enter your physician name, last name, email address, patient info, and you can select IOL. Say you have to intend to correct 4 diopter of cylinder in the corneal plane, but you only put the calculation only 2.74 correction. So which these software give you the what could be the best with this lens. So you can put this lens and all the kind of, you can put the other lens also. Thus you can put the Indian lens and how to similar in the corneal plane, axis of IOL axis, and what diopter of lens is given, and it will calculate beautifully what to do in this. Then this is a absolutely good software. Everybody can free and everybody can use. And iTrace also has a Geldiver Toric caliper, but it has a problem. It never allowed to input what lens and what diopter intended to correct in the corneal plane. So you should match your corneal astigmatism, which calculated in the iTrace system, and it is matching with the biometry system. Otherwise, rotation would be the overestimated or underestimated. So our IOL alignment, ideal time is alignment study shows after 3 weeks, because there is a little bit of fibrosis in the capsular bag. But role of CTR definitely prevent or reduce IOL rotation. No, but it is not routinely recommended. But it is, you can use the it's myopic cases where the actual length is more than 25.5 or 26. And some surgeons prefer to implant routinely in multifocal toric. And the most of the surgeons prefer it because you have a very narrow landing zone in a multifocal toric. So this is one of the best, the Anderson type of, but this is unfortunately not available here. This gives excellent rotational stability of the IOL. Contraindication of the CTR, late interference and fibrosis expected. So it is very, venture is sometimes very dangerous. You can rupture the capsule. So IOL rotation can be clockwise, anti-clockwise. This is the only lens I saw in the anti-clockwise rotation. Is basically technistoric. So you have to wait for the complete unfolding of the lens. Alignment, early alignment, most of the Indian scenario have to intervene early because it's very difficult to explain patient regarding this. So we generally do the next week or the 10 to 14 days. It is advisable, do not inflate the capsular bag OVD if you are re-rotation within the 14 days. And you just inflate the anterior chamber, the viscoelastic, and rotate the back. But be careful. But if there is any traction, you should inflate it. A late rotation 3-4 weeks, and this is a case. I'm just finishing 2 cases. This is a the same days I implanted wrong in 2 cases. This is a Toric plate haptic design, and I rotated without inflate the capsular bag, just putting the viscoelastic into the anterior chamber. And this is the case. I do the same thing. This is a see after rotation there is a fold. So I planning to do a CTR in this case. So one should be very careful when you rotate the lens. If there is any resistance, inflate the bag. Otherwise, if you don't find any resistance, don't inflate the bag, then it will be more stable in the postoperative. Thank you so much for